and it will follow some of the things that we came up with, but we're talking about, I've got an idea of doing care kits that we can use internally. So we'll hear more about that next Sunday. So that's the next few Sundays, and I hope that that sounds exciting to y'all and will be useful to y'all. So I'm gonna turn it to Joanne and Kathy. Thank you for getting our speakers together, and I'll have Joanne and Kathy both introduce their speakers.
Margaret, that was such a beautiful prayer.
So real quick.
Oh,
you want to do that?
okay. Well, and you can get these at the end. Next Sunday, 2:30 to 4:30 is the Souls to Poles, where we will meet over on the west side of town at Clark's Funeral Home, hear a few speakers and caravan over to the polls. It's a very powerful event. So we'll make sure everybody gets one of these.
And last year, we'll send out a note to all the Crossroads. Last time we did have few meet here. So if you want a driver, I'd be glad to meet over here and drive some people. So if anybody wants to not, it's a very lively event. People are, they're speech making, but the whole goal is to get pretty much West Ocala out to vote. That's the primary goal, get people excited about voting next week. Yeah.
In fact, that's the last Sunday they'll let you vote, right?
Yeah,
they won't let you vote the 2 days before.
Early, but yeah. It's very exciting. I took my ballot.
Well, I just went, your prayer was wonderful and just kind of focused us on our need to be sensitive to and learn even more about how to show love to people who are end of life, dealing with really difficult illnesses, dealing with dementia. And so we've got 3 fabulous speakers today. And Kathy's going to introduce Alyssa, but I know these 2 women, Amy Roberts and Mary Lasada, very well. And they are just both remarkable women. And Amy will speak first. She has been a trailblazer in oncology and the use of mindfulness in particular to help people deal with all that goes with cancer. She has her license. She's a licensed clinical social worker. And for the last 10 years, she's been working at the Robert Boysonoff Institute with patients and families there. And she's been honored basically for her work on a state level as well as a national level. Because it really is trailblazing. And she's currently the chair of the Cancer Alliance of Marion County. And she specializes in mindfulness meditations. And I had not only at the Institute, but also for retreats for community members. I had the real pleasure of going to half of a 2-day retreat. And it was, I can't wait for the next one. It was just really, really special. So, so we're looking forward to hearing her talk about dealing with cancer patients in particular. And she also has her own mindfulness, Imperfectly Mindful.
Yep.
Right, is the name of your group, which is fabulous. And Dr. Mary Lasada is an advocate and expert in the field of end-of-life medicine and palliative care. She's a board-certified physician, a diplomat in psychiatry and neurology, and a fellow in palliative medicine, which is a remarkable combination.
And I like baking, so any recipes.
She's the chief medical officer of Hospice of Marion County and other affiliates of Empath Hospice. Medical director of Care Well Support. I mean, I could go on and on and on. She also teaches at U of F in the Department of Aging and Geriatrics. And she's also involved in the bioethics committees, both at Advent and at the HCA hospitals here. So we're very lucky to have you. So, Kathy, you want to introduce Alyssa, and then
We've got to start
what?
Start recording.
I did. Oh, yes. Okay. Don't stop it.
I actually had never met Alyssa before I called her on the phone, but as a former high school coach in Marion County, her husband was one of the great coaches at Forest High School and men's basketball. But I have a really good friend who works with her as one of the nurses at RenStar. And I'm very interested in what RenStar has to do with the clinical trials in Alzheimer's, because I have my whole family on my father's side pretty much had Alzheimer's. I was a caregiver at the age of 18 for my father with my mother. So the research that's gone on in all these years since I was 18 is remarkable. So as a science teacher, I'm very interested in that. And also I'm going to probably be in one of the trials for the preventive type of, I guess, assessment of myself with some of the risk factors that I may or may not have, since I'm only 62. But anyway, so I talked to my friend, sir.
How do you get into that stuff?
And she might tell me that. Well, her titles, she is a recruitment specialist, but also a manager at RenStar, and her background is in healthcare administration. And her friend that I happen to know that works with her is a nurse. And so I had gotten some information through Sharon Cohn. So I want to say her name for thanking me with this, meeting her. So I hope some of the fallacies on the differences between Alzheimer's and the other types of dementia, she might be able to tell us. There's also a testing that we all can do for free from RenStar with memory issues. So I'll leave that for you to tell. But I've also heard your name so many times with my friends that have, you know, of course, gone to voicemail, and I also heard your name. So I'm so glad to have all three of you here. So thank you.
Okay, so we've asked Amy to go first. Okay, and then Mary, and then Alyssa, and each of them will speak for about 15 minutes, and we'll have a chance for questions, even if we go over a little bit.
Yeah,
So-
we can do questions after 10.
Afterwards.
It's just,
Oh, after, okay.
we
Yeah.
have some people that leave at 10, so it's not because they don't like the program. They have to go get ready for requirements.
No, may do something.
I will attempt to.
So, so Amy,
Start.
you may start. Go ahead.
I can't. So hi, everybody. Can you guys hear me okay? Am I speaking loud enough?
You might want to stand near the cool pro.
Change seat. Oh,
The closer you are to the cool pro, the better.
I'm
okay.
sorry, my face is in the
That's
way
okay.
too.
Just barely loud enough.
We like your frames.
Oh, we're talking to Joanne?
Yeah.
Oh.
I put in my contacts this morning. Okay, so they asked me to speak on what are the, let me do this in order. How to help patients and family deal. What are the needs, and I think that's it, but
Can we do a
I'll
sound
start.
check? Are y'all hearing?
and Zoom.
Or
Not-
Zoomers,
not-
are you hearing
I
okay?
can't-
Are you hearing okay, Louise? Just do a thumbs up. Yes, okay.
Bridget said
Thank you,
Yes,
Bridget.
yes, I can.
Okay, so first off, I guess, there's a couple little truths that I've learned about people that are facing cancer or probably most any illness. One of them is that people never want to feel pitied. So if that's true, you guys, right? Anybody that's been through anything, that is just one of the biggest things is do not feel pity, do not feel sorry for me. That feels extremely uncomfortable for most of us. We don't appreciate that kind of an energy. So I would say that. Another kind of universal truth, I think, is that sometimes people may not be afraid of the end results, but what they are afraid of is the process. So am I going to have dignity? Am I going to have autonomy? Am I going to be able to manage my pain? Do I have a say? Do I have a voice? So I would say those two things are pretty much universally true for most anybody dealing with an illness. And that's pretty hard to say something's true for almost everybody. But I think those are two of the kind of the core things that are true for everybody. And everything else, it just depends. So any other advice or rules or guidance, it depends on the day, the moment, the mood, where they're at in the process, any number of factors, it just depends. And because that's true, it makes caregiving and reaching out and supporting people very confusing Because one day I might be like, I need people to ask me how I'm doing. I'm hurting. I feel alone. I feel isolated. Somebody come up to me and just give me a hug and say, hey, how are you doing today? And another day, I may want not to talk about my cancer at all. I'm sick of people asking me. I just want to laugh. I want people to ask me who I am outside of my cancer. I want to have fun. I want to have a good moment. And you don't know from 1 minute to the next. Sometimes I don't even know if I'm the patient from 1 minute to the next, which little category I'm going to fit in. And so that makes caregiving and offering support and loving on people very, very confusing for everybody. So because it depends, what I always try to do is put on that little like a social work training hat that says start where the person is. And the only way I can start where the person is by doing what? You can hear me. Is by asking, and by listening. Really, it's the listening that is the most important. You may ask and they may not really want to talk about it, and that's okay. But listening is how we know where we stand with someone, how to support someone. Even as a patient or person with an illness, listening to my own body, my own needs, my own mental state is where I would start as well. And so sometimes we're so busy that we may not know that. And so trying to think of how I wrote this here. I guess the first part, if you want to listen, is to check yourself first. Because I might be in a state where I have been working all day and then caregiving and then making meals and thinking of 10 other things. And I had the car breakdown earlier. And so my energy level to listen and be supportive and be a good caregiver and be present with somebody may only be at like 10% today. But maybe after dinner and a little time reading a book, my energy level might be at 80 or 90%. So sometimes we're not able to listen right in the moment that it's needed, and that's okay. So part of being a good listener is knowing how much energy you have to listen and how much energy you have to give. And then finding some way to do that dance with your partner or with the person that you're taking care of, right? So I saw a cute little clip from Brene Brown. She's a clinical social worker, and she talks about her and her husband. They come home at the end of the day and they go, well, how much do you have and how much do I have? Because your energy level, right? You're supposed to all give 100%, right? But we don't always have 100%. So she says, some days I might come home and go, look, I only got 20% to give. I am exhausted. And the spouse might go, well, I got you. I've got like 100 today. I'm good. So sometimes it's finding those cute little ways to check in with each other, figure out your own little language as a couple or as a mother-daughter or whatever, to say like, where are you? What's going on? How can I support you? Or I really can't right now. I just need some time. I've just got to find a little break. I need to get some food in me or a nap or whatever it is. But I promise I'll come back to this and we can be good, sweet to each other, kind to each other. So that's that mindfulness that Joanne was talking about is, where am I at inside? Do I have the ability in this moment to be a good listener, to be very open and be very compassionate? Or do I need to use some words to say, look, I need a little space, a little time. I'm going to come back to this, that kind of thing. Is that helpful for you guys? Does that sound realistic at all? Or does that sound very realistic? Okay, good. All right. I've used up 10 minutes of my time. The other thing I wrote down, and I'm used to people just asking me lots of questions, so is leaning into your strengths. So as caregivers, some people are really good emotional space holders. They're comfortable putting on that listening hat, reflecting back what the person is saying. So creating good space and being very calm. And other people are doers and fixers, and that's their strengths. So sometimes it's nice to know what your strengths are. And as somebody needing support, you can pick the people in your life that are good for what things, if you're fortunate enough to have a nice, robust support system. And that's why it's also nice when you have multiple people in your support network, if possible. Sometimes you're the only one, and that's rough. That's rough. So it's nice to have church communities, building friendships where there's other people that can offer other things. The only other, I guess the last, let's see. I have so much that I could talk about, so I'm trying to narrow it down, but these guys will have great things to talk about too. I guess the other thing is, since we were talking about communication, there's a few things you can do if you need to have a heavier or difficult conversation with somebody, or even just in the day-to-day. But when somebody tells you something, you're going to have a conversation with them. Think about your setting. Are you cooking dinner and doing 10 different things? Or are you able to sit down and have some time and really give the person your attention? Are they catching you outside in the parking lot? And is that okay? Or do you need to say, look, right now I just can't, but let's schedule some time to meet up and have a cup of coffee. So think about your setting. Think about that self-check, right? And then when somebody needs to share something very heavy, or if you need to share something heavy, you want to start where they are and you want to repeat back what they say. So let's say I'm talking with somebody. This happens very frequently when they're newly diagnosed with cancer. The person dealing with the cancer says, you know, I always thought I would never do chemo or radiation. I can't believe I'm sitting here. I'm not sure this is something I want to do. So when you hear that as a child of that person, what is your gut instinct, or as a spouse? No, stop, right? We have to do everything. Your own reactivity, your own love just pours out. And sometimes you just jump right in and you just want to rescue and save and negate everything they're feeling and everything they just expressed. And those things are hard to express. To say that out loud is hard. So sometimes it's kind of noticing that gut reaction, maybe taking a slow breath, maybe counting to 5, and then reflecting back on what that person said. Gosh, it sounds like you never imagined you'd be here, right? You're not agreeing with them necessarily. You don't have to. You're listening. You're telling them, I hear you. I hear where you're at. I hear what you're exploring and wrestling with, right? A lot of people need to wrestle with that stuff so that they can be okay with whatever decision they make. Whether that decision is, I know I never thought I wanted to do this, but now that I'm here and I'm sitting in this seat and I've got these cute little grandbabies and I've got so much life I want to keep living, I think I want to learn more about chemo, or I think I want to learn more about radiation. They might reach that point, or they may really just say, you know what, this is not something I want to do, but at least there's that space to kind of explore it and talk about it and feel heard and feel understood by the person that means the most to them. And if you're able to do that for them, then hopefully they're able to do that for you as well. You know, so that you can say the things that are heavy on your heart. You know, I hear that this is really hard. I hear that maybe you don't want to go through with this treatment. It's really hard for me to hear because I care about you so much, but I will respect what you're saying, right? So you get a chance to kind of say what's heavy on your heart. And so when we step back a little bit and we kind of feel that reactivity, and we take a few breaths and we repeat back what they say, even if we don't understand it, or even if we don't agree with it, we can say, I don't really understand this. Can you tell me more? Can you help me understand? I want to know what this feels like. I want to know what you're thinking. I want to be a good spouse to you. I want to respect your wishes. These are all things you can say, but at the same time also questioning, because it is important for you to, you know, wrestle this with them, right? You're in it with them. You're showing up to all the doctors with them. So I want to understand. Can you tell me more? I think I'm hearing you say this. Is that right? Is that what you meant when you said this? Because this is what I'm hearing, but I don't know if that's what you meant to say. I think you're feeling this way. Is that right? So you see how you're just kind of teasing out and making sure that you're understanding what they're saying, but at the same time, in many ways, you're helping them feel like, oh my gosh, this person hears me, they're with me, they're in it with me, they've got me, they're gonna be a good advocate for me as I go through this journey, and I'm suddenly not alone anymore. It's not me versus the medical team, it's me and my loved ones. So yeah, that's my 15 minutes. So I was and we'll be questions at the end.
Up now?
Yes.
And Mary, I'm going to the hot seat.
Yep.
Yeah, do you have slides do you want us to put the PowerPoint up?
If you have it,
We do.
absolutely.
Let me see if I can, okay. All right. Oh, so it's not just share? I wouldn't hit share, okay. Okay, okay. I hope it doesn't.
Yeah, yeah.
Sure.
I hope it don't
So,
blow it all here.
Tagging along, what was it? Amy was talking about, I think usually when I talk to my caregivers, I commend them because when you become a caregiver, you're expected to become the best nurse, the best doctor, the best social worker, the best lawyer, the best cook. Yeah, you become a nutritionist. So all of that is supposed to be happening just right away, just because now you're the caregiver. And when you were talking about, I'm a 20%, what are you now? I could imagine how to design a charger, when you plug a cell phone and you charge, because we all, will benefit from that. So being a caregiver is a very difficult work. Nobody prepares anybody for that. And it's a great idea to sit in a group and support each other, because that is essential. Because nobody can do this by yourself. So it's good to have support. What are you doing?
I might
Be able to do it.
I just didn't know how to make it go forward.
Sorry.
Get a little laughter.
No one would notice.
And you're invisible. You're like, we're talking about 3-year-old invisible.
Yeah, right.
Yes.
I got intro.
Just hit enter.
I got
So just for you, I did a new presentation. What about that?
Oh, look at that.
Well, that's what we're trying to get set up.
You got it. It's there. Are we on the right side, Mary, or?
Yeah.
Okay. And I'm scared to change view. I think.
Okay. And can we
I got
see-
it.
we can see you too, Mary.
Okay,
Okay.
Yeah, this works.
Yeah,
If
okay.
you, it's on the view, I know. Where is the view? Here it is, here it is. Nope.
You're supposed to be minimizing in there. Okay, never mind. So, probably the important slide of the presentation is, the last one with their phone numbers. Okay, so we're talking about support. So, there's a lot of support, and we are in a lucky community. You will be surprised how much work gets done in our community, by you all. So I'm very proud whenever I have the chance to work in different counties, and I usually go and show off my Marion County out there, because of that. So, I was charged with the role of defining what is end-of-life care, what is hospice care, and what's palliative medicine. In reality, those definitions are in the book. In real life, those boundaries just melt with each other. Because how do we know we're in an end of life? By definition, we could be that today, and nobody has sent us an email, say, by the way, you're checking out tomorrow, get ready. So that is, my grandfather used to say that the only requirement to die was to be alive. So whenever I start talking to my patients, I say the only difference that between you and me is that we told you we found an X-ray, we know a PET scan, we know an MRI, we know. I don't know if I'm gonna crack in my way back home because I'm driving 200. I may die before a few, so I tend to be ready every single day just in case. And I just carry on with my day because I don't know if it's going to be the last one. So whenever I see a piece of chocolate cake, I never know if it's going to be the last one, so I go and get and take it. By now, end-of-life care has become a specialty in medicine. So we get trained for that. We get the medical students coming and spend time with us. I have taken care of patients that are related to medical doctors, and the medical doctor has never seen anybody dying. So I'm teaching this person, and I know he's a doctor, and it's say, well, don't you see that she's dying? I says, well, no, I'm an eye doctor. I've never seen anybody dying. Like, well, that's right. So it doesn't, we can't assume that we can identify end-of-life care just because it's happening. A lot of people have a lot of barriers, a lot of ignorance in that. So we get the medical students to come along with us. We get the residents there in town to come along with us, so we teach. I spent this week, just as a refresher, being the caregiver of my mother in the hospital, and the big shot doctor is coming to do the consult was my medical student 6 months ago. So he comes all big, I saw the name and I knew it was you. And I want to make sure that you know that how much I have applied in the emergency room when I learned with you seeing your patients. So that I checked out the date, I did my thing, so I'm done. So can you give me the next one?
Just tell
please?
me.
So by convention in the United States, because that's also local, I crossed the border and I went to give a lecture in Guadalajara, and I was doing my usual talking with no sense now in Spanish, and they were looking at me like I had 3 heads. Well, it happens to be the palliative and hospice are divided by that 6 months mark only in the United States. If you go out of here, palliative medicine is all of what we do. And if you die in 6 months or 6 years, it's okay. They don't make the difference. So and that is my very much unique individual opinion, because I have gotten into this argument with a lot of big shots at the academy, but it's an artificial division, and Medicare says that if you have a terminal condition, you may qualify for hospice care. And the doctor that is certifying that is writing in a piece of paper that you're supposed to be dying in 6 months. If you don't, we may come back and do a reassessment and say, well, you're still at risk. You still have all these markers that look like you may be, God knows when, it happened. So we recertify you for 6 more months and we'll go from there. There are patients that get better. We graduate people from hospice all the time and say, oh, guess what? You didn't die. So I'm gonna discharge you. The next time you try, call us again. And so because it happens, there's at this moment we have so many chronic illnesses that they fluctuate. They get better, they get worse, they get better, they get worse. So if I get you in the point that I see you in the hospital and one of your crises and you look like, you look like you're dying, I may tell you, say, hey, let's have this conversation because this is what may be happening. What about if we go home, get better, and go from there? And we'll take it as it is. The importance is that the person doesn't feel abandoned, because what's been happening, patients go to the hospital, they have had their primary care physician for 10, 20 years, and then they go to the hospital, they're taken care of by a completely different group of strangers. They don't know anything about them, and then they get discharged. And then they may get discharged home, and the primary care has no idea what's happening. And so there's a whole of difficulties in that kind of the progression and continuation of care. So the palliative care team, I see it as the support in the hospital. I explain going to a hospital is like going to a different country. Who was talking about going to your cruise? We're talking about the guy in China. If you go to a different country, you have a different set of rules. We speak a different language. Hospital language is completely different out. There's not a dictionary for that. We don't teach anybody else. That is our own private language, right? So it's like it's a KGB type of language, so nobody else. So we try to confuse you. I think sometimes we do it for the purpose of becoming important. So the more complex that I speak, the more I know, right? So I appear to be more important. So, the first thing we do is telling you what the rules are. Get your clothes off, so we get you naked, which psychologically speaking is a setup for regression. So we're gonna have you, depending on how you mentally you are, and some people like to be mother, some people hate authority, and now we're gonna get you naked in the chair, telling you what to eat, what not to eat, when to get up. My role this whole 5 days has been trying to keep my mother in the bed because 3 different alarms ring at the same time because she doesn't wait. So, I'm going out. And she's jumping over the rails, going to the bathroom, say, I have told you to wait. She won't do it. So 5 alarms ring, 3 people running to the room, like she went to pee again. So all these rules make you feel that exposed, vulnerable, confused, and we don't help them when we go to the hospital. So the palliative care becomes that team that is going to be explaining you what the creatinine means, what the EKG means, what the CT scan means, what the echocardiogram means, what kind of chemotherapy they're talking about, side effects and all of that. So they become that support in the hospital. So if you go to any country and you know somebody there, the first thing you do is say, hey, dude, I'm going to France. Where should I go to eat? What should I avoid? How do they dress up? Do they really wear that beret? It's the same thing when you go into the hospital. Call a friend that is in, let it know that you're going there. And if you don't have anybody, you can always ask for the palliative care team to get a consult so they can help you to explain what's going on. That doesn't mean that you're going to die right away or 6 months later. It means that the palliative care is going to help you to understand what is the disease process you're going through, what is the best way to deal with the disease process, and what may be coming from there. Okay. Now, if your disease is to the point that we have a prognostication of 6 months or less, the best care for that will be hospice care. It becomes a very difficult conversation. And one of the lectures that I do with my medical student is that a difficult conversation. We talk about setting the stage because you don't want to do this in the stalls of the bathroom. Say, oh yeah, I was told that I was dying and I don't know what to do. Who should I call? And the other person and the other stall, well, you should be calling Amy. She knows what she's doing. You want to set up a stage somewhere private, somewhere that you can confide, that you can explain, that you can see that emotion, that you can acknowledge that emotion, that you can intervene with that emotion, because it's a very emotional conversation. We all know that we're going to die, but we don't want to talk about it, right? I was on vacation in Cancun and I love a tequila bottle. So I walk into the store and says, I like that tequila bottle. I don't know anything about tequila. I just like the bottle. And so I want to buy that one. And the woman says, hey, okay, but why that one? There's so many other colors. No, I want that one. So say, and? Oh, I want the bottle because I would like to use that as an urn. It's a beautiful bottle. That woman turned pale, blue colors. Dead and died, right? So, that's my urn. It's like people talk about the coffee, but no, I like that one. In the middle of my vacation, right? So that kind of situation, we don't like to talk about it, which is something obvious. And then we get to the point, we don't get prepared, and we leave everything a big hot mess for everybody else. So what if we have in common between hospice and palliative? We all taking care of the human being. We all taking care of symptoms. We all taking care of in a holistic way. One, we promise to die in 6 months. The other, we don't have to. Okay, so pretty much like both they get paid by insurance. So palliative care is seen as a consultation, like a cardiologist, surgery, anything like that. In hospice is a benefit from Medicare. So anybody that has Medicare signs a like a contract where you say, well, Medicare is going to provide me now with hospice care. And that's why those conversations about insurance and coverage comes when hospice is. So we're talking about the difficult talk. There's an app for those that, like to be tech savvy. There's an app where you can learn tips. And I love it because every day when I kind of not in my 100%, I go and check a tip in case that I mess it up that day. It's called Vital Talk. And the Vital Talk people is people that have been teaching other people how to have difficult conversations. And they came up with the idea to have an app. It's for free. Yay. So, and it gives you tips, how to have the conversation, what not to do, because we have the best intention ever, but, we do things and we put our food in our mouth and doesn't help anybody. So it's very helpful for that. But creating a space for privacy, for, for attention. You're here, I'm here with you. We're gonna have this conversation and I'm all yours. This thing that we have here, I usually tell my patient, it may ring and I can't avoid that because I have 100 people calling me. But as soon as I off the phone, I'm back with you. Okay, so I explain that so they understand that I may have to get at that. When we talk about being a good listener, is listening. So you have to let the other one talk, because we love to tell people what to do and we mean well, like I'm a doer. I don't know how I became a psychiatrist because I can't be the neutral psychiatrist. I have a problem, I had to give a solution. So I had to control myself on that. Always ask questions. So when in doubt, I always ask why. I learned that when I was learning English, and you tell me something, I had no idea what you say, and I say, why? So that usually brings you back to repeating what you just said, and probably in a different way, and may have a better chance of understanding what you're saying. So why are you feeling like that? What is making you feel like that? Tell me more about it. That is helpful for that. Tell me when I'm in time, because I'm bad.
No, they want to look at
They
you
wanna look
instead
at
of,
you.
instead of the slides.
Oh,
Is that okay?
Wonders, can we email the slides
Yes.
later
Yeah.
so we can see
Well, I'm
you?
not in my best game today. I spent the whole night in the hospital. So I don't blame them.
Okay.
Stop sharing.
Okay, she's saying, can you do it without your slides? Because I'm,
Without the slides?
yeah,
Oh, I have them here.
okay,
Absolutely.
good, because they really want to see you.
I can talk.
We'll email the slides later.
Okay, okay.
So the only one that will lose that if I have a stroke or have Alzheimer's, but I'm not yet there. So we're talking about asking questions, and that is usually helpful to find out what are you needed about. At this time, I have one of my classmates. When we did med school, we became either siblings, couples, or big enemies forever. So because we lived 10 years together. So this girl, she was one of my friends in there, and she calls another one of the class. And by now, of course, we are in a WhatsApp all over the world because my class spread all over the world. And she was diagnosed with ovarian carcinoma, and she's by herself with her mother in Venezuela. There are no resources. There's no chemo. There's no immunotherapy. There was not even morphine. And she called me on a Wednesday at 10 p.m. crying because she's in pain. And my husband, we are watching something because we have a spreadsheet of what we're going to watch every night. And that night was something stupid. And we are in the middle of something there. And he say, what's going on? Like, well, she's dying. She's in pain. She just called me, the usual. So what do you tell a person like that? I just listen to her. Okay. I just want to hear what her fears are. And her fears were that, what's coming. Say, I am not afraid of dying, she said, because I think I've done good while I'm here. What I'm afraid is, what's going to happen between here and the point of checking out. So I'm not going to be in pain. Is this pain that I'm feeling going to stay with me? Is my belly going to continue to grow like this? What can you do for this? And this is a doctor. Okay. So it's any human being idea, regardless of where you're coming from, what your education is, the fears are very common. It's a universal fear. Some of us add the afterward as scare. So what's going to happen when I checked out? What is the guy going to say about me for what I did here? So some people add that stressor, but most of the people talk about the process. My primary care told me, there's nothing else for me to do, or there's nothing else to do, and send me to you. So, well, meaning that I'm going to do nothing, right? I don't know if I'm doing nothing all day long, why I'm so tired in the afternoon, because we have to spend this whole day doing nothing. So we still have a lot to do just because you can't do what is called aggressive treatment. I can still be aggressively treating your symptoms. So I can still aggressively treat your pain. You don't have to be choking in your saliva. You don't have to be choking in your shortness of breath. That I take care of. And for that, I went to school. That kind of talk we have to have in there. We feel, and there's a podcast that I listen all the time. So things happen for a reason. And that lady interviewed Alan Alda, the guy from MASH, and he is actually teaching communication in the medical school in Duke. So he's a communicator, and he said that he uses what theater has taught him, how to use the facial expressions, how to use the body language to actually communicate with the patient. because we have this fantasy in medicine that because I said it out loud, you heard me, you understood what I said, and you're gonna respond in a logical way to me. And that's very far from the reality. You know, most of the time patients hear what 10% of what we said. The fear they have, the anxiety they have, the hearing problem they have is gonna let you just take 10%. From that 10%, they may remember 1% of that. And then we're expecting them to make big decisions about it. So the other bad habit that I get into trouble with my co-partners in medicine is that we don't explain options to the patient. I go to my primary care, I don't exercise, I love chocolate cake, my cholesterol is high, and the answer is you had to go on a diet and take a pill. What other options I have? Is anything else to do instead of running 30 minutes a day? Can I walk 10 minutes 3 times a day? So make the same 30 minutes. Let's talk about options. So options are good because you don't feel trapped. So if I can tell you, well, you don't want to do chemo, well, but you may have the immunotherapy that is not necessarily chemo, and we can do radiation. You don't have to do it twice a day because the doctor says so. We can do once a day because I understand that being in the machine for 45 minutes twice a day with pain, with shortness of breath is not an easy cake. So let's meet in a middle point and see how that goes for you, because there are options. I draw a lot. When I'm sitting down with my patients, I do a lot of drawings because that stays with them. And so they can reflect to what we talk, and then it goes a visual. So it's if I tell them you have 50% chances of making it or 50% chances of this, they have it in their hand. So the doctor told me, and it's here. So it's like it becomes like a commitment with them, with options. When I used to do more practice, you come in with a headache and I will give you a graph and I will draw it with you. So you see, and we add things there specifically for you. What are the 4 different options of headache treatment? So you will make your choice. I'm not taking the pill, it's you. So I can give you what the book says that you could do, and you make the decision. Next time you come back here after you do your WebMed check and tell me which poison you have chosen so I can give it to you. So that kind of thing is.
Dr. Lasada, I wish we had scheduled
That's okay.
3 separate hours.
It's okay.
Talking about valuable. Go ahead.
Two more. So I was asked about the act of kindness, and I think that is why it grounds me in our community, because there's so much. My son asked me why the news are always talking about bad things. And to say, yes, you're absolutely right, because it sells. The war thing, the blood, the war, all these bad things sells. The good things are, that's nice. Okay. I like the Good Morning America has a little spot that says, the good vibe or something like that. I just watch it just for that one. The rest, I don't even pay attention to it, because those good things ground you on what's going on. You will be surprised how many people are in town. They're the only people they have is the church people, the neighbors, the other support systems that are in town, because they have nobody else. So that tells me that the good people are more than the bad people. So just one got shot last night, and that is just one bad guy that is out, right? The good people are more, and we're doing a lot of work. So this work that you guys are doing here is very important, because it brings the good, the love, the kindness. So what kind of act you can do to help, just preparing a little bag with something, with Clorox wipes, for somebody who is in a distress, they feel that there's nothing good happening to them. It may mean the good thing of the day. So we were moving, I'll tell you what another adventure that I'm doing these days, but they called me because there's a shelter in Bonnie Heath that they are closing. It was a specialty shelter, they're closing, and when they cleaned up, they found 5 people in there. They were all connected to an oxygen concentrator, and their homes had no electricity. And the shelter people are looking at each other like, now what? Because we can't send those people back home with no electricity because they are hooked on an oxygen source. So they called me. I'm supposed to be going and solve that problem. So And that is, those are the situations that we did, and it was a deployment of people, the health department, the major senior services, the fire department. They called me as a representative of hospice to solve the problem. So there's a lot of kindness in there. With this friend of mine, everybody's calling her, I'm so sorry, this shouldn't happen to you. The most useless comments that you can do with anybody that is sick. All my friends who are all doctors are telling her that. And I'm here thinking, what can I do from far that can be good for her? So I've been sending her videos with music. So it's like, how are you doing? How's your pain? Please tell me what else we're gonna do. Today music is. And I sending her music that we used to dance when we were in the 80s, the music that we used to dance when we were celebrating. And music is very powerful because music is connected to emotions. So that emotion that we were happy, then we were dancing in the med school, that is important to her, connect the two of us, because nobody had to explain to us what that music means, because we know, and give her something cute, something cool to look at least for 5 seconds, at least for 5 minutes. So that may light up that. So those little acts of kindness when we are caregivers are huge. And it means a lot. So don't think that, these little things that you're doing, they're not little, they're very powerful. Okay. And the last slide is our phone numbers. Okay. So those phone numbers, just keep them, use them. They are there in the community. There are more. So if you need patients resources booklet, we make one in hospice. Migrant Services is carrying another one, so I can facilitate that for you guys, because it's very helpful. Where to get a family law lawyer, where to get food bank, where to get a Meals on Wheels, where to go to the doctor's appointments. The American Cancer Society has a system. We have another system in town to get to your doctor's appointment, and then maybe make the difference to each one of them.
So we can probably send that link when we send your slides.
Correct.
Okay, thank
Thank
you.
you.
Thank you. Y'all want to flip?
Yeah.
Get there?
I'll be quick into the plan.
And don't, you got more than 5
Okay.
minutes.
I mean,
We
we
will
don't
just
start
know we
church
will
till
have a few
10:30.
fire
Okay.
people longer. We don't have church till 10:30, so we have some flexibility. We just
Okay.
want to be sensitive.
Okay. So I'll touch on what RenStar does. There's a couple familiar faces in the room, so I love that. So in a nutshell, and then I'll tie it to caregiving too, but RenStar is a multi-specialty clinical trial site. So we have been around for 26 years. We do clinical trials in various diseases, from Alzheimer's, Parkinson's to weight loss, and everything in the middle. So this gives the opportunity for the patient to have access to testing, lab work, imaging, physicals, in addition to their standard of care. So we're not taking you from your doctor. This is all in addition to what you're doing. It's just another resource. So talking about Alzheimer's specifically, because I think that's probably what you see the most of in terms of dementia, memory loss, in caregiving, too, is Dr. Lasada and Amy talked on it. It's leaning on your support, right? So if you don't have someone, right, if you don't have a spouse with you or a daughter, a sibling helping you, right, and you're at 20%, what are you supposed to do, right? It's like parenting when you're a single mom and you're maxed out. You have no one else. You can't say, tag, you're Ed, right? So it's creating that network, and I think you guys have the ability to do that, of a list of people that you can lean on from a caregiving side, whether that's family, friends, but having that list, because no one likes to ask for help, right? We all like to think that we're heroes and we can do it all on our own, and we have this. And sometimes we have to admit, we can't do this. We can't do this by ourselves. We need help. So a lot of our patients, we just tell them when they're in a trial, or just coming to us for resources, is create that list. So when you do need help, you can go to that list and you don't feel bad saying, hey, Mary, I just need you to come over for 30 minutes so I can run to the grocery store by myself, and then I'll be right back. So I think that's the biggest advice that I have outside of what RenStar does. My story is my mother-in-law was diagnosed at 59 with Alzheimer's disease. So she's now 61. And we're going to get into the conversation of taking her keys very, very soon. A mom that raised 4 kids on her own, does everything herself. And so I know that conversation is going to be really difficult.
So we're doing everything we can to allow her to keep that independence, like having a tracker on her car and having a tracker on her phone. But she's also not stupid, so she has left and turned that tracker off. So we have to figure out a way that she's not able to do that. But I think it's really realizing that these are people, right? Especially in memory loss and dementia, is they are human beings and they are changing. And they may admit they're changing or they may not. And it doesn't matter. It doesn't matter if they know that they're changing or not. It is up to you as the caregiver to change and to adjust and meet them where they're at, like Amy talked about. It's meeting them where they're at. It's finding ways to still allow them to have independence. And whether that's, a severe dementia patient that is, likes to clean the house, give them a mop with water. Who cares? Who cares if they're actually cleaning the floor? So a lot of times it's about us as a caregiver relinquishing some of that control that we're so used to having, and allowing them to just keep their independence because that's what they want. So in Alzheimer's dementia specifically, how many know the difference between dementia and Alzheimer's?
Between what?
Dementia and Alzheimer's. You do. Okay, and what is dementia?
Dementia is a little fault in the brain, and it can be serious or it can be very light.
And do you know?
I never knew. I drove 20 years with dementia, never knew it. And there was a lot of people doing that.
Yes, sir. And do you know what's contributing to your dementia?
What is it?
What's contributing? Like, do you have an underlying disease that's causing those symptoms?
No, I'm pretty healthy.
Okay. So how we like to explain it is dementia is like an umbrella, right? So it's like saying you have cancer, right? What type of cancer do you have? Do you have ovarian cancer? Do you have lung cancer? So dementia is the symptoms, right? And Alzheimer's falls underneath that. It's the disease causing the dementia symptoms. So in Alzheimer's, it's still a diagnosis of exclusion, right? So we're doing the testings to ensure that your blood work is stable, you don't have a B12 deficiency, a UTI, any other things that could be causing your memory loss. So at RenStar, one thing that we offer as a community service is memory evaluations, right? Nobody wants to know how their memory is doing. We all have colonoscopies, we all sign up for mammograms, like we sign up for these really vulnerable things, but the most non-invasive memory screening, nobody is knocking at the door. So it's really important for various reasons. I think one is just to have a baseline, right? So if we start to decline, we don't know where we started because we have nothing to go off of, right? If we had a colonoscopy today and we go back in 5 years, well, I know what my colonoscopy was 5 years ago. I don't know what my memory was 5 years ago, other than what I can say or what my family can tell me. So having it as a baseline is always beneficial. And then patients that are noticing changes but don't want to say anything, right? So like my husband's not going to run to me and tell me, hey, I feel like my memory's going, because we know what we're going to anticipate with his mom. So having us as another resource. And then a second opinion too. We're not diagnosing you, but we're giving you additional information with your doctor. Some physicians have 5 minutes to spend with you. Some have 25 minutes to spend with you. And a lot of patients, unfortunately, get a diagnosis and then they're pushed out the door and they don't know where to turn. So they're calling us and saying, hey, I was diagnosed with Alzheimer's disease. I don't know where to go. I don't know what to do. And so something we can offer is Dr. Lasada and her team, and then also support groups, right? So unfortunately, a lot of the support groups aren't advertised, right? So hospice's support groups are advertised. But there's a lot of smaller, intimate support groups that we're just aware of from being in the community that we can provide that to you. Again, the resource booklets, we also provide those on behalf of hospice and Marion Services, just to make sure that you have all the resources you need. Because a lot of people will call us and they don't necessarily want a trial, but their spouse is incontinent, or they need access to a walker. Things that you don't think about. And so I like to say research is a resource. Don't think of it as research, a guinea pig, all these negative connotations. We are strictly a resource. We are a tool for your toolbox, just like the rest of them up here. you can never have enough tools, right? All of our husbands and spouses have way too many tools, right? And multiple tools of the same thing. So there's never enough for your toolbox. So through RenStar, you can do the memory evaluation. We'll give you the results. Yes, they're paper pencil tests, but a lot of it is just the one-on-one conversation, right? Identifying things that maybe you did in the past that you're not doing now. A lot of people have retired, not because they wanted to retire, but things were changing and they knew they needed to step back, or their daughter, son noticed some things were going on. So they've mentioned it and they're coming to us. There's various reasons why people come to us. And then from there, we can discuss the Alzheimer's research that we're doing. So RenStar has been lucky to be a part of the newest medication on the market for Alzheimer's disease. And there's still a lot of work to be done, right? Medication is extremely expensive because there's only two now. So they're very, very expensive and not everybody has access to them. So through RenStar, we can do the testing, which is like Kathy mentioned, some of the biomarkers around Alzheimer's disease. And I'll kind of clear the air on Alzheimer's is not genetic. You have a risk factor. But just because my mother-in-law has it does not mean my husband's going to have it, right? So we would test him for the risk factors and see what his risk level is. He can still have a higher risk and not get it, or get it later in life, right? Because she was younger, there is a higher chance because it's early stage Alzheimer's. So there is a higher risk of the children developing it, but it is not genetic. So some of the local labs like Quest, LabCorp will do some of those, but through research, you can also get them as well. And then through research, you have access to the very specialized imaging, which is a PET scan, but it's a PET scan very specific to identifying plaque buildup in the brain that research thinks that is contributing to the Alzheimer's disease. So that's what we're doing. So I just encourage you as a group, right, is to lean on each other, ask for help when you need it, lean on the resources in the room as well. And then a lot of you are going to be the ones that see changes in people of the church, right? So when we're home with them all the time, sometimes we don't notice it because it's, he's 80 years old, he's old. That's not the case. There is no number, there is no age, right? Age is just a number. I actually am the one that noticed it in my mother-in-law because I knew what I was working with and I knew that we just had a conversation and we had it again 5 minutes later. So she used to watch my children. She does not anymore. She watches my oldest because my oldest will tell on her. So there. And we give only food that does not have to be cooked. So, we've made adjustments, right? Because I want her to not feel like I'm taking her grandmother duties away from her. But I also know that safety is a role, right? So I'm not going to leave her with my 3-year-old. Because last time the only thing he ate was pouches all day, which is fine for 24 hours, but not for any extended period of time. So, we still allow certain parameters and allow her that independence to be with her grandchildren. So it's all about adjusting, again, meeting the person where they're at, figuring out what they can do, how you can still instill that independence with them. But if you have any questions, I know I'm over on RenStar memory screenings, anything specific to that, feel free to ask. I did bring some caregiver booklet resources and some bags for you to take.
Oh, thank you.
Great. We have a question back in the back.
I have this, I was gonna cry, but I'm good.
We can cry.
Okay, so there's been a lot with my dad. He's 80, I'm 60. Huntington, Korea recently seen. Is that something that you do with Huntington, Korea?
We do not do anything with
Because
Huntington.
I am so desperate and I gotta just get his doctor, because my kids are now having kids and want to know, because it is, it's genetic.
So yes,
And early dementia, and he got a UTI, and he's in the hospital, and now he's home. And
so what I hear from you is that your dad has Huntington's disease?
Yes,
Okay, and he's here in town?
no.
Okay.
And
So-
that's part of the, no. it's in
Correct.
Arcadia.
So, in every town, there are resources for that. So you can Google Huntington's Disease Association Foundation. You should be able to take, resources that are local for
Right.
where your dad is.
Right.
For the family that you have close by,
Right.
if you want to get into the genetic testing, it's highly recommended to go to a genetician.
Genetician.
See, that's what, okay,
University of
and
Florida.
that's what I'm
Yeah.
trying to do for me,
Correct.
and I'm willing to pay some.
So, but to go to that kind of testing, you have to be aware what you're getting into, okay? You did great about learning how to deal with people that had different political ideas on that. So there's a lot of different political ideas on the genetic testing. So you had to be aware what you're getting into. So part of the going to a consultation with a genetician is to learn the pros and cons of knowing, okay? Most of the diseases that we can't modify, like Huntington's disease, one of those, we have symptomatic treatment, but we don't have modifying therapies, right? So what do you want to know? What you really want to know with the information? All those are questions that is very personal, and you should have it one-on-one with the genetic specialist, so you can answer those to the best of the information that we have at the time that applies to you. Ocala Regional has a clinical genetician that she's based in Gainesville, but she comes and does consultations in here.
Is it, so just, and then I want to know if I have that gene, don't I? Wouldn't I want to know? Or is that, I know
That is something that only you can answer,
Okay, I wanted.
and they can, yes,
I said wrong,
and
but-
exactly. And then the genetician will can figure it out. Why do you want to know? What are you going to do with the information? How is that going to be affecting you?
And I'd appreciate if that didn't leave this.
Yeah, absolutely.
Okay.
Thank you, panel, and Dr. LaPlata. These two questions are for you. Will you talk, or it's asking you to explain the immersive experience for caregivers that hospice has?
For
people,
dementia?
The workshop, and then I understand that you all are converting one of the hospice houses specifically for dementia training and maybe adult care.
Or we're doing a lot of things just on dementia, which, I'm drooling about it.
Yeah.
So the way I started doing, when I landed in here in the US, that's how it started. I started working with a memory disorder clinic at and since then I've been working with dementia patients. So it's been more than 30 years for me of experience. Actually, Huntington's disease is very close to my heart because we have a pouch in Zulia where it's the highest incidence of Huntington's disease in the whole entire world. So I had a Huntington's disease person having a child at age of 30. So that's how terrible that situation is in there. Locally, we have different programs. So we have the Nancy Reinhardt Dementia Educational Program, which is doing what you're talking about. When we talk about identifying with a person that has the illness, be empathetic with that person, we don't really understand what that person is going through. So the gentleman is talking about a fog, right? So sometimes you may have the fog if you had too many wines the day before and you wake up this morning like, I want to wake up. Or you have a jet lag and you imagine having that a cloud on your head constantly, right? All the time. The cloud gets bigger or gets smaller depending on how active or what that charge is that day. So it's difficult for the other person to understand what the affected person is going through because we have been together for 40 years, 50 years, 60 years. This has been my dad all my life. And now how can you tell me that you don't know how to do the screwdriver if you were a mechanic? So it's very difficult for the caregiver, people around to understand what the limitations is. So the immersion virtual dementia program is trying to teach you as a normal person, what is the other person going through? So each one of the senses get affected by disease like dementia, regardless of which flavor it is. So what is looking like, or how does it feel like going into a room where your visual field is limited, your tactile information is limited, where your feet are not doing the right thing, and you can't hear well, and we are telling you to go and do, get your clothes, put her in the suitcase because we're going to work at 8 o'clock. Okay, so that kind of immersion, that kind of identification with the person that has the problem is very powerful.
It's profound. If any of you can do it, I had, my entire team did it, at our clinic, and our clinical director, even of 26 years, was speechless. It is just an experience that puts you in, and sorry to interrupt you.
Oh, that's fine.
Puts you in their shoes, that you gain this sense of empathy you have never, ever felt before, right? And so it just allows you to understand how overwhelming this person feels every single day. And here we are getting frustrating at them because we had to repeat that you have an appointment at 10 o'clock 20 times. It doesn't matter. Say it for the 21st time, right? Because they are experiencing so much. So if any of you have the opportunity to do so, I do.
And if you
recommend
come
it.
as a group, this is a perfect setting up for doing that. So I can get you connected with DJ and set up a meeting for that. Oh, we'll come to you.
Yeah, they'll bring it to you.
Probably do one more question and then if folks
Well,
want to.
Susie, I think.
Oh,
had her hand up.
Oh,
No, they're just. They've been there.
Before I get there, I want to go back to, so we are turning one of our houses into a daycare / education center because we are copying what is done in Arizona. They have a huge, beautiful facility where they have all kinds of resources, but they got something like $22 million. I just got 300,000, so I had to adapt to my budget. But that is part of the project. And we also are part of the Guide Dementia Program, which CMS has been trying to come up with programs that are called Innovation in Medicine. And so we are part of that, and we're going to be setting up assistance to the caregivers. So this is not just the care for the patient, but we're going to be providing support to the caregivers once they're diagnosed. So she can go and get one of her screening tools in there and say, you're gonna need help with that, call the Guide program, see if you qualify because you're on Medicare. And so that caregiver will have support for education, help at home, and that kind of program. So we, as the umbrella of Hospice American, we are participating in all those programs only for the diagnosis of dementia. So
What's the timeline for the adult daycare program?
we're hoping for next year, for middle of next year.
So-
So how do we do the memory screening?
Yeah, so I brought interest cards. You can give me your information or you can call me.
There's resources here and there's resources here.
They're cut off.
Susan, did you have let me get these guys. Susan, did you have a question? I saw Lenore's hand, I think has been up
It's been there the
whole
whole
time.
That's a cursor mark.
That might be on our machine. Okay. Judy.
I asked her, cut off for her test, for the memory test, and she said no.
Okay.
Age.
Okay.
I didn't know if you stopped it or certain.
Well,
Or no, we don't stop in age. Actually, there are studies in that what they call the older, so the older elders. And at the time when I did my research for some time, so at the time we were doing research, the cutoff was 89.
Yeah.
Now the closer that we get to that one,
Yeah,
right?
they push it back.
So,
You're living longer, so we'll push it a little bit.
No, but is Melba still on?
No, Melba's not on, but she's 102.
102.
We had 100.
They took her out of the hospice that they had for her originally because she was over 100. When she got to over 101, they kicked her out of that one because they said, "You're healthy." You're still
yeah.
kicking.
Amazing.
Only when you try it again. So
Yeah,
that's pretty
right.
much, the conversation. The good news is that you're not dying yet. The bad news is that we're gonna have to walk away from you. So.
Well, I agree with Joanne. We could have had a whole program on each. I know you've given up your Sunday morning. Thank you.
Oh, no, we're so grateful. Thank you.
And
Thank you.
I do have to do that quite often. Yeah, but he's just.
I know the gesture of finding the shirt, but to go to a foreign country for a damn thing.
Yeah, I'm gonna do that.
It was very interesting, Louise.
Excellent presentation.
Yes, it was. That's right. We should have had one at a time.
Yeah.
Could ask
So many
more questions.
Lots of questions.
We'd have had time for more questions.
Yes, yes. I'll see you later.
Yes.
Hopefully to be continued. Thank you.
Thank you. Thank you. Please have the paperwork at the office for people like the little brochures. Okay.